Hello friends, this is a case of left-sided complete indirect irreducible inguinal hernia containing omentum in a 55-year-old gentleman. So we have planned for a E-Tep hernioplasty. So we have entered through the right retrorectus space. Initial camera port is placed around 3 cm cranial and 5 cm lateral to the umbilicus on the right side, and initial dissection is done with the telescope. Little bit of oozing of blood is there, which will be controlled of its own in most of the time. Then first working port is placed around 4 finger below the camera port, medial to the right semilunar line. Then after checking hemostasis, we are taking down the flimsy adhesions which are holding the right rectus muscle from the posterior rectus sheath, and small blood vessels are also taken down with monopolar cautery using a hook. So now we are taking a few fibers in the medial end near the linea alba to enlarge the right retrorectus space, so that we can easily place our second working port at or just below the umbilicus. As this part is posing difficulty in putting the port, so we have decided to take down the fibers and also the branches of the right inferior epigastric vessel. So we are gradually going further and enlarging the space, and also taking down the small blood vessels with coagulation current. So now we are cutting the posterior rectus sheath near the midline, near the linea alba, so that we can easily place our second working port at the level of the umbilicus. Here care has to be taken not to injure the peritoneum or make a hole in the peritoneum. Then one may have difficulty in doing the dissection because of the pneumoperitoneum. The space may get collapsed. So with external pressure we can check whether we have reached at the level of the umbilicus or not. So I think we need further taking down of the posterior rectus sheath. Now we are checking with a spinal needle, and so now with needle guidance we are putting our second working port at the level of the umbilicus. So with a fenestrated grasper on the left hand and a cutting bipolar on the right, we are further dissecting to reach the space of radius towards the lighthouse, that is the Cooper's ligament. as you can see, this is the Cooper's ligament on the right side, which is called the lighthouse. One needs to go slowly so that there is little bleeding and the field is clean, then it becomes easier to dissect further. So this is the pubic symphysis on the midline, and on the left of the screen there is the left Cooper's. So now we are going towards the space of Bogros on the left side. So on the roof, shortly we will see the infraepigastric vessel. The infraepigastric vessel should be kept on the roof. Now we are dissecting little bit medially in the space of radius. This is the left Cooper's ligament, and this is the left external iliac vein. This is the infraepigastric artery on the left side. One has to be very careful here and should dissect very close to the infraepigastric vessel to prevent injury to the peritoneum and cause pneumoperitoneum early. So we are taking down the fascia transversalis. To enlarge the space of Bogros. After initiation of the anesthesia, we have tried to reduce the hernia with external pressure, but was unable to do so. So we are dissecting here and we will be trying to reduce the contents again. But even with external pressure, it was difficult to reduce the content, that is the omentum. So we are dissecting, we are trying to reduce with external pressure, as you can see, but the contents are not coming out, probably because of adhesions. This is the gonadal vessels. So we have decided to dissect further. trying to separate the vessels from the sac to do the paratalization as well as trying to reduce the content. So this is the pseudo sac, as you can see on the distal part, and this is the due to the pull, the testis also has come into the vision. So we have decided to cut open the sac to check why the contents are not reducing, which is probably because of the adhesions of the momentum with the sac. So as you can see, there are adhesions of the momentum with the sac, and that's why it was not reduced even with external pressure after anesthesia. So we have decided to do the adhesiolysis to free the momentum, and then we'll try to reduce the content. Even now it's not going away because a lot of momentum has stuck into the sac. So we have decided to open the sac again proximally to help it reduce the content. If there is any bleeding, it's better to control as soon as we can see it, so that the field will remain clean. So we are enlarging the opening of the sac, which will help to reduce the content. So the contents reduced, now the testis is pushed back through the deep ring into the scrotum. Now we are going to reduce the content. We are also trying to dissect the cord structures from the sac, that is the vas and vessels from the sac. One should not catch hold the vas and vessels to prevent injury to those structures. So now the vas and vessels are separated partially from the sac. One should not transect the sac before putting the contents back, because it will be difficult then to push the contents back. So now we'll reduce the content, then only we'll transect the sac, and we'll try to reduce the whole of the sac as far as possible. And before transecting also, better to close the proximal end, because the traction or the attachment with the distal part will help to close the or take the sutures. Now with caution we are pushing the vas and vessels away from the sac to do the paratalization with occasional diathermy to control the bleeding. So now we have decided to close the proximal end of the sac, and then we will transect the sac. It is always better to keep the sac attached to its distal end, which helps to take the stitches. Otherwise, if we transect it beforehand, it will fall down and taking sutures will be difficult. So now again we are trying to dissect the sac from the vas and vessels and reduce the sac as much as possible. So almost we have reached till the distal end of the sac. So now we have decided to transect the sac here. checking again whether vas and vessels are intact or not. So carefully dissecting the sac. As you can see, this is the vas which is protected. Now we are transecting the sac with hemostasis. Now we will transect the sac here. Now we will do further parallelization of the cord. And we will try to achieve the hemostasis also. So it is said that the parallelization is complete when the vas turns medially, as well as if we lift the proximal end of the sac and there is no transmitted movement in the cord structures, then also we can assume that the parallelization is complete. So the vas is turned medially, as we can see here. A little bit of dissection is needed to bring the peritoneal fold down and also dissect the gonadal vessel laterally. So laterally now we are going to make the space of Bogros by taking down the fibers of the fascia transversalis. Here we can see we are holding the peritoneum and pulling it down and proximally and dissecting further to enlarge the space of Bogros. Here laterally one should be able to visualize the belly of the psoas, and now laterally we are further enlarging so that we can easily place the mesh. So we are cutting a few centimeters of the posterior sheath, that is the arcuate line medial to the left semilunar line. We are taking down the posterior sheath for a few centimeters so that it will be easier to place the mesh. Unfortunately, there is a small rent that happened in the peritoneum, which I will repair later. The nerves are usually on the muscle, so one should not go very deep and do the diathermy. So the dissection is like almost complete. Now we are going to close the peritoneal rent with 2-0 Vicryl. 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 2-0 So after checking for hemostasis, this is the triangle of Doom. Medially the vas and laterally the gonadal vessel, and inferiorly the peritoneal fold, and on the lateral side there is a triangle of the pain, the laterally bounded by the iliopelvic tract and medially by the gonadal vessel, and inferiorly the peritoneal reflection which contains the nerves. Again checking the cut end of the sac, and a small hole is present. So instead of taking chance, I decided to close that gap also, though it was very small. One has to be careful in those cases where the indirect sac is cut and sutured, that it was repaired very meticulously, otherwise through the rent the bowel content may go inside and cause obstruction. So now we are placing a 15 into 13 size flat polypropylene macroporous heavyweight mesh. So the mesh is lying comfortably, and the proximal end of the sac is lying above the mesh. Now we are removing the sac and the needles and do the desufflation reinsufflation test to check the position of the mesh. So as you can see, the mesh is lying quite comfortably and flat.